I'm now pleased to introduce to you our guest speakers for this evening. We have with us Dr. Aila Spiegel, Dr. Elizabeth Jackson, and Professor Susan Leckband. Dr. Spiegel and Dr. Jackson are in their second year of psychiatric pharmacy residency at VA San Diego Healthcare System in this hospital here. And Professor Susan Leckband is the lead mental health pharmacist at the VA San Diego Health System and associate clinical professor of pharmacy and psychiatry at UC San Diego. So we have three experts in this field. And this is a great opportunity to ask lots of interesting questions. Please welcome our guest speakers.
Okay, so like Mike said, we're pharmacists, so we're going to be talking a little bit about medications today, specifically medications for bipolar and depression, and some of the more common side effects and how we treat them. We figured we'd keep the actual talk relatively short, and then we can just kind of do a Q&A so we can go over the things that you folks are interested in and not bore you yapping too much about medications. Just to give you a little bit of an overview, some of the more common medications you might see for bipolar disorder and also for depression, since there's a lot of overlap, are mood stabilizers, which include medications like Lithium, Depakote, Carbamazepine, Lamotrigine, as well as the atypical antipsychotics, which can also serve as mood stabilizers, even though they are also antipsychotics. That includes things like quetiapine, ziprasidone, risperidone, lorazepam, aripiprazole, all of the dones, as well as antidepressants such as selective serotonin reuptake inhibitors. That would be things like Zoloft, that kind of thing. The SNRIs, which would include things like duloxetine or Cymbalta or venlafaxine, Effexor, and then other antidepressants like mirtazapine or bupropion that don't necessarily fall into those other categories. We'll start off with lithium, since that's one of the more common medications for bipolar disorder. Some of the more common side effects for this one that people complain about are tremor, so shaking in the hands. Stomach upset can be a big one, things like nausea. Polyuria or excessive urination sometimes people will experience. Cognitive side effects like people feeling kind of slow, feeling kind of cloudy, that kind of thing. Potentially changes to your thyroid, and then also changes with your sodium balance or your electrolytes. In terms of managing these side effects, for tremor, there are a couple of options that we have. You can either split up the dose, so instead of taking it all at once, you're taking it multiple times throughout the day. That can help. You can also switch to a longer acting formulation, so the type that releases into your bloodstream a little bit more slowly throughout the day, as opposed to the immediate release. That can help with the tremor. Or we can also do things like add on medications like Propranolol, which is a beta blocker that's normally used to control things like blood pressure. But we find that that also can help a little bit with the tremor that people get from taking lithium. For stomach upset, we can have people take their lithium with food, or again, we can try switching to one of those longer acting formulations, and sometimes that can help folks with things like nausea. For excessive urination, we would actually do kind of the opposite of what we do for tremor, so you can switch to a shorter acting formulation, or try to consolidate the doses into one so you're taking it less frequently throughout the day, and that way it's not having to go through the kidney so much. For thyroid changes, generally for this, if people are otherwise doing well on the lithium, we'll just go ahead and put them on thyroid medication. So treat folks the same way we would if they had a thyroid issue that wasn't caused by the lithium. For the issues with any kind of sodium balance or electrolytes or salt in your bloodstream, we just encourage people to stay hydrated and also to have a consistent salt intake, so not having a diet that changes rapidly from one day to the next. Valproic acid or Depakote is another one of the more common mood stabilizers. Again, some common side effects with that one include stomach upset, again, the tremor, things like sedation, feeling tired, and then weight gain can also be a common side effect that people complain about. Again, and I'm sure you're going to notice similarities between a lot of these, but for a lot of these medications, if you're experiencing stomach upset, you might be able to take the medication with food that can help people. You can potentially switch the formulation, so sometimes people, if they're taking it as a liquid, they might get more stomach upset. And if you switch to taking it in a pill form, that can be helpful for some people. For tremor, again, we can add on that Propranolol that we talked about with the Lithium, the beta blocker that can help with tremor, or we can switch to a longer acting formulation. For sedation, we can have people take the medication at bedtime, so that way if it makes you a little bit drowsy, at least you're going to bed, so it's not going to affect you so much throughout the day. With weight gain, there's not quite as much we can do generally. We encourage healthy lifestyle, diet, exercise, and then there are other medications that we can potentially add on if that's not helpful. And do you want to take over from here?
Sure.
Okay.
So carbamazepine or Tegretol, this is kind of a repeat of the Depakote as far as the side effects go. So there can be similar side effects with Tegretol as to Depakote, including sedation and weight gain. And again, in order to minimize the sedation, we would typically dose it at bedtime. And the weight gain, we would again encourage healthy lifestyle and healthy diet choices. Lamictal or Lamotrigine, this one is often used in patients who have a lot of depression in their bipolar disorder. So like with bipolar 2 disorder. One of the big things we worry about this medication is rash, and that's why if any of you have been on Lamotrigine, you know that it requires a very slow titration. You increase the dose very slowly over time. If patients do experience a rash on Lamotrigine, sometimes what they'll do is, as long as it's not a severe rash, sometimes we'll take them off and then try increasing again even more slowly. Other than the rash, this medication tends to be pretty well tolerated. Some people can feel a little bit sedated, which again would make us want to switch the medication to using it at bedtime. So the atypical antipsychotics, these were the things we went over in the beginning, things like Abilify, Latuda, Seroquel, those agents. One of the things that we see them very often in different antipsychotics, and it varies by the medication. So there may be more with Seroquel as opposed to things like Abilify, but we'll see potentially weight gain and then metabolic side effects. And by metabolic side effects, I mean that you can see increases in your cholesterol and increases in blood sugar. And this can even occur even if you don't gain weight on the medication. So as far as managing this, again, like with the other medications, we would encourage healthy lifestyle, so diet and exercise. But for the antipsychotics, there's also some research into using medications to help either prevent weight gain on the antipsychotics or help with weight loss once you've gained weight while being on the antipsychotic. And these are things like Metformin, which is often used for diabetes. And also a medication called topiramate, which is often used for weight loss in patients even not on antipsychotics. And again, if the medications are sedating, such as Seroquel, we try to dose them at bedtime. Another side effect that we see with antipsychotics, particularly with ones like Latuda or Abilify, is something called akathisia. And akathisia is really a sense of inner restlessness. So people will say, oh, I feel restless. Oh, I feel like I'm crawling out of my skin. I just feel icky and like I always have to move. And this can actually be quite severe in some patients, so we do want to go ahead and try to treat it. Some things that can be done are to add the Propranolol, like we said with the tremor. This can also be helpful for akathisia. And in some cases, you will have to add a benzodiazepine, which can also help to treat the akathisia. Extrapyramidal symptoms. So these are other movement side effects with the antipsychotic. So sometimes people will notice they have rigidity in their muscles, or they might have a tremor, or notice that they're kind of shuffling when they walk. And in this case, what can be done is sometimes we can decrease the dose or start a medication like Benadryl, and that kind of helps to balance out the hormones and make it so that the movement side effects aren't so severe. Antidepressants, so we see antidepressants used in people with major depressive disorder and sometimes in patients with bipolar disorder. And there are several side effects that can occur with the different antidepressants. So a lot of people will experience headache, especially in the beginning. Usually this does subside over time, and we usually recommend to try something like Motrin, not if you're on lithium as well, or Tylenol, and to try to help with that. Also, sometimes people will notice stomach upset, especially in the beginning, so we try to start it off slow and tell people to take it with food. And then another problem that some people will notice are the sexual side effects. So this can include things like erectile dysfunction, anorgasmia, which means they either takes longer to have an orgasm or you can't have an orgasm at all, and decreased libido. And sometimes this can be hard to tease out because a lot of times when people are depressed, you'll have decreased libido as well. So sometimes it can be hard to tease out whether it's the medication or the underlying disease. But if they do think that it is due to the medication, one thing that we can do is potentially switch to a different antidepressant or add another antidepressant on that has a lower risk of the sexual side effects. And those would be agents such as bupropion or mirtazapine. And also in some patients, they found it useful to add Viagra to the antidepressant regimen. And also another thing that is done sometimes is people will take drug holidays, so meaning they'll take some time off of the medication. But that's for it's in very specific cases. Also with antidepressants, some medications can cause insomnia, some can cause sedation, and while there are agents that we think are more likely to cause sedation versus insomnia, everyone's different. So you may hear something like Prozac is supposed to be activating, so you want to take it in the morning, but some people may experience sedation with that, so it's really finding whatever works best for you. So if the medication is making you feel awake, then take it in the morning. If the medication is making you feel tired, taking it at bedtime. Also, some people experience dry mouth with certain antidepressants, and really what we recommend here is trying to stay hydrated, potentially chewing sugar-free gum or sucking on sugar-free candy, or if it's something that's really bothersome, then we may try switching medications. And also in people with bipolar disorder, there's always a concern about the potential for either switching someone into mania or causing a mixed state when starting an antidepressant. So that's something that we really want people to look out for. And in that case, a lot of times what we will do is either take off the antidepressant or ensure that they're also on a mood stabilizer as well to prevent sort of that switch. And I guess that's the culmination of all of our formal presentation. We wanted to make it short just so we could kind of give an overview and then let you all ask questions in whichever part of this is of most interest to you. So thank you.
So we're going to be entering into the first stage of Q&A using index cards. So if anybody needs an index card, let me know. And then if you have questions, just put it into this bag. And then we'll pull out the first set of questions from this bag.
I don't think so. Lithium's the opposite. Here's Lithium right here. That's just Depakote, right?
No.
Have you heard of biotin too? Someone else told me biotin as well. Well, that's rare.
Okay. Susan also suggested that we point out that with the Depakote, sometimes people do experience hair loss or hair thinning. So when that happens to folks, sometimes we'll recommend that they take dietary supplements like zinc or selenium, and that can help people too.
And oftentimes, your standard multivitamin will contain zinc and selenium, so it's something kind of check for.
Okay, so let's get the bag and start the Q&A. You can still hand forward the index cards.
Thank you.
What's at the bottom? Okay, any more questions? All right, we'll start the Q&A. Okay.
We also have some from the beginning. Should we?
Oh, good.
Yeah.
There's mine.
Just put them on there, and I'll mix it up so that everything will stay anonymous. Okay, so you guys can pull one out and read and answer.
Shall I read them too?
Sure.
Okay, first question. Does atypical antipsychotics affect the conception of a child if the man is on a medication?
If the man is on the atypical antipsychotic,
Not that I'm aware of. I mean, it might cause sort of issues with sexual dysfunction, which can cause kind of secondary issues, but I haven't heard that it necessarily makes people unable to conceive children.
or cause, I've never heard of anything about it causing either birth defects or any issues with fertility in the male when they're taking the medication. Again, like Aila said, if there's issues with erectile dysfunction or like something like delayed ejaculation, then it would be more difficult to get pregnant potentially. But as far as that goes,
So are there sexual side effects from atypical antipsychotics?
there is the potential for sexual side effects. So sort of like what I had said with the antidepressants, so risk for erectile dysfunction, delayed orgasm, that kind of thing. It is a potential. And again, it's one of those things, like I said, it can be difficult to sort of ascertain whether that is from, the symptoms themselves or from the medication.
Are there any natural options?
Any natural options?
In lieu of antipsychotics?
No, to manage sexual side effects.
Rekindle love. I don't know.
I mean, so there's yohimbine
Is that effective?
and horny goatweed.
The horny goatweed.
Generally, we don't really recommend the over-the-counter kind of more natural type things because you don't necessarily always know what's in them, and sometimes they can have interactions with other medications that you're taking.
And what else can they do? With your blood pressure?
Oh, yeah.
So a lot of times those kind of medications are just like Viagra. Do you guys know how Viagra works? No? Okay, so a lot of times Viagra's and the reason they tell you not to take it with stuff like nitroglycerin or heart medications is because Viagra is a vasoconstrictor. So the blood goes into the area like the penis, but then it vasoconstricts. So the penis will stay hard, but they won't let the blood go back out. Sorry for the visual, but effective.
You're doing good, yeah.
Effective. So anyway, the blood goes into the penis, but it won't flow back out. And this is why what they'll tell you if you take a medication and the erection lasts for 4 hours, not to call all your friends and post it on Facebook, but, to call the doctor because you have to have recirculating blood or you'll get cell death and nerve damage and all of that bad kind of stuff because you have to have blood flow and all of that. Because that's like a tourniquet, and that's not a good thing to have. Well, the stuff that they sell, sometimes that can be really bad. Plus, you don't know the dose of it. You don't know what else there could be in there. There's no kind of regulatory control on what you get, and what is constricting on the blood vessel. Sorry, visual again. Constricting on the blood vessel can also constrict the blood vessels in your heart. So those kind of natural products, not recommended at all. There are some other natural things that they do sell, like pumps and stuff like that those actually do work. But if anybody experiences any kind of sexual dysfunction, the first thing you need to do is go see your urologist, because there are a lot of other reasons why people have sexual dysfunction, like prostate cancer, blockage, urinary tract infections, all kinds of things that really need to get checked out. So we tend to we tend to blame a medication when it might actually be something else entirely. So okay.
Oh, that kind of reminds me too, kind of on a related note, I actually saw an article recently where one group of researchers actually did a DNA analysis on a lot of these herbal supplements to try to check what was actually in them, and it was kind of scary because with some of the brands, it turned out that like the vast majority of them didn't actually contain what they said they did, or they had something else, or it was mostly just like ground up corn. So you don't really necessarily know what you're getting with all of those.
No. Okay. Are psych meds meant to be lifelong treatment? Ooh, good question.
I think it depends. It really does depend. I think it depends on what you're using it to treat. So, let's say someone has something like schizophrenia, they're likely going to be on a medication for life, whereas someone with major depressive disorder who may be having their first depressive episode, they may not require medications for life. However, the more frequent or the more recurrent episodes that you get, the more likely you're going to get even more recurrent episodes, which is why people who have had major depressive disorder and have had more than one depressive episode, we tend to keep them on antidepressants because they're much more likely to have a recurrent episode. Also, people who have family history of suicide, family history of depression, those would also be people who it may be smart to have them on lifelong treatment because you're just at a higher risk for recurrence or for negative outcomes with depression.
Aila, what do you think?
I agree with that. I mean, to some degree it is kind of individual, but especially like Liz mentioned with things like bipolar or schizophrenia, a lot of times folks are on the medications for life. And sometimes, if somebody's been stable on a medication for a really long time, sometimes their doctor will maybe try to go down slowly and see what happens. But again, like Liz mentioned, if there's some risk that if the person does go back into an episode that they're going to commit suicide or spend all of their money or things like that, then the doctor would probably be a little more hesitant to try that just because the outcome could be so much more serious.
So my answer is we don't know. I think this is a really good question because it's a really difficult one to answer. And there's a couple of additional questions that are all related. The answers here are, the more recurrent the illness, the more severe the illness, the more the family history, the more likely the treatment should be continued. But first of all, we don't know what we've got coming down the pike in the future. We've got a lot of research going on right now and a lot of treatments that are in the works, a lot of studies that are being done looking at not just treatment of symptoms, but actual cures for diseases that I think in our lifetime we're going to be able to find cures for things like Alzheimer's, and schizophrenia and many of these diseases. Do we want to cure bipolar and depression? I don't know, because there's a lot of positives about creativity and having good days and bad days. I guess we would want to maybe cure some of the extremes would probably be good, but I kind of like having good days and bad days, but I guess not some of the real extremes that can lead to running down the street naked or being hospitalized or whatever. But so we don't know. There are some people that are able to go off of medications after they've been on them for a long time. We get some people who get what they call bipolar burnout, where when they get into their 60s or 70s, they stop having significant mood swings. So that can occur. The second part of this question is, what are the lifelong the long range effects of taking medications on the brain indefinitely. Do you guys have an answer for that one?
I think it really depends on the medications. Like for some of them, for instance, like the antipsychotics, folks who are on those for a really long time might be more likely to develop the long-term movement disorders that are called tardive dyskinesia, where they kind of have these like involuntary movements of maybe their mouth or kind of might be rocking back and forth. But other medications lifelong, like things like antidepressants, there's been some research to show that it might actually have almost like a healing effect on the brain, where people who have long-term uncontrolled depression, if they do those brain scans, sometimes they'll see like actual brain loss, but then people who go on antidepressants, they'll see that it kind of almost like restores the brain. So it really depends on which medication we're talking about.
And that's definitely true with lithium.
And with lithium as well, yeah.
And then significant brain damage with drugs like alcohol and amphetamines. Big time damage with that. And then when do you know if it's okay to reduce or eliminate psychiatric medications? Liz?
When do you know? Well, I think this kind of is related to everything we said earlier, really. I mean, if someone has not been doing well on medication, has been less stable, then that would not be a time to decrease the medication. However, if someone's been stable for a long period of time, I think also it depends on how severe things were when they were bad. So, you know, if someone was depressed to the point where they had multiple suicide attempts, again, that may be more of a reason to be more cautious in considering tapering or decreasing medications. However, I think it really is patient specific. It's specific on how long you've been doing well, how easily it's been to control. It's a hard question to answer because there is no one good answer.
Does anybody have any comments for that question?
Well, I have one, just based on that thing. Do, after a while, certain, especially antidepressants, or I guess if it's falling any other drugs, but can there be a time when some of them just stop being effective anymore?
Yes. We eloquently term that pooping out.
Prozac poop out.
So that does happen sometimes for certain people. If they're taking an antidepressant for a long time, sometimes they'll notice that it just isn't as effective anymore, in which case we switch them to something else.
Is that common, or is that something that's very rare?
No, it's
in between.
fairly
It's not
common, yeah.
Okay.
common, but not rare. It can happen.
Thank you.
I think there's another.
Aha, this is a good one. What happens if I take Motrin while taking lithium?
Bad things.
Really?
No,
Kidney damage.
So, the thing is, with certain pain medications like ibuprofen, things that we call NSAIDs or non-steroidal anti-inflammatory, so ibuprofen, naproxen, things like indomethacin, they have an interaction with lithium in the kidney where taking these medications can actually cause your body to hold on to the lithium, so it can make your levels go high. And in that case, you could potentially have, more side effects. And in some people, it can cause their level to go quite high, where they become confused, that kind of thing. So we recommend that if someone's going to take a medication for pain, Tylenol is one that often can be used, and then if you go to your doctor, there are some prescription medications that are less likely to interact with lithium, and one of the ones is called salicylate, if anyone here has been on that, and another one is called Sulindac. I just remember it as the S's, salicylate and Sulindac. But the other ones do have the risk of increasing the levels.
And it's actually worse if you're taking them as needed. So if for some reason you absolutely have to be on one of those medications, it's better if you take the same amount at the same time every day, because if you're kind of taking this amount one day and then not taking it the next, it can cause the lithium levels to fluctuate more, and it can be more damaging to the kidney.
So while you're on this, can you talk about salt and water and lithium?
So, okay. So as far as, salt, the whole thing that Aila was talking about earlier with the salt balance, so lithium is a salt. So your body kind of sees lithium the same way it sees sodium or salt. So the reason why we want people to keep a fairly regular amount of salt in their diet is, let's say that someone gets dehydrated, so they are losing salt in water, so like you're sweating a lot. When your body notices that it's losing salt, it's going to try to hold on to the salt. And when that happens in the kidney doesn't know how to differentiate the sodium from the lithium. So your body will try to correct its salt, but at the same time it's going to end up increasing the lithium. So you have the risk of getting very high levels of lithium. Whereas on the other hand, if you're greatly increasing your salt intake and your body's like, I don't want to hold on to salt, you could get low levels of lithium because you're trying to get rid of it. So it just treats it the same way as it would treat sodium. So in cases where you may, dehydrated, losing sodium, your lithium level is going to go up.
Yeah, it's essentially the same as just taking a higher dose in a way.
I just remember it because I had a patient who said that every time he ate pickles, he got manic. So pickles made him manic.
Yeah.
So I just remember, salty pickles made him manic. So that's how I keep it in my
Was this like
head.
immediately or like
Yeah.
after several days of pickles?
No, he would eat a pickle and the next day he was manic. So that's how I remembered it.
Interesting.
So pickles make you manic.
How many pickles do you eat?
The
Like, it's
whole
gonna be
jar.
one pickle.
Big, huge pickles. You had your finger up. Were you had a question about? No.
I did
Question
back
back
on the stuff with the sexual side effects.
Uh-huh.
One area, we didn't like the stuff at the stores, right? But maybe there's some books that are helpful. One particular book I've been made aware of, The Joy of Sex.
Yes.
It may have some techniques that are helpful.
Absolutely. Good recommendation.
I'm just going to say on the topic of medication, what about aspirin for pain relief?
Aspirin you can take. Aspirin you can take, and then the over-the-counter ones that you can't take. So we mentioned Motrin. What are the other ones? Aleve, right. No Aleve, no Motrin. And then make sure also if you have a cold that you look at the back of the package and read what's in it, because a lot of times it'll have an antihistamine or a decongestant, but it'll also have ibuprofen or naproxen. So.
And what about small amounts of alcohol interacting with?
Well, what does alcohol do?
Alcohol is dehydrating.
Dehydrating, right.
Yeah.
So you can get really dehydrated. Oh, here we go. Another sexual side effect question. Okay, so regarding sexual side effects, reduced drive as an effect. Are buspirone, mirtazapine, or bupropion effective for females? I'm assuming that's a female. Yes. Okay, female.
Yeah, they should be, because actually the way that it's thought that the antidepressants actually decrease the libido or cause the sexual side effects has to do with certain subtypes of serotonin receptors. So it's not necessarily the type of genitalia you have, it's more something to do with the way it's altering chemicals in your brain, so they should work for both genders.
But it's Viagra.
Well, I don't know about Viagra so much, but those other ones.
I've heard women
There's
take
some
that sometimes.
people that
Yeah.
think, because it still can increase
Yeah.
blood flow, but I think it definitely doesn't have any evidence like it does in men.
Right. Yeah, I don't think it. Not for the medication-induced, I don't think it does as
And-
much.
Yeah.
Has anyone here heard of the new female Viagra that got approved? I don't know the brand name for it, but I know the generic is Flibanserin. It works actually very similar to mirtazapine. It just happens to only act on that one receptor. But we're kind of using that same effect, like you said, with the serotonin. And they've actually made this female Viagra using the same thing, but it's only that one effect rather than all the other things that mirtazapine does.
So we're actually using an antidepressant in addition to another antidepressant to kind of remove the side effect, the conflicting side effect. So.
Yeah, in case there's any confusion, the Viagra does work more on the blood flow, so that's more like working on the other areas of your body, but the ones that mentioned here, like the mirtazapine and the bupropion, that actually works like in the brain. to counteract the sexual side effects. Was there another question?
And remember, we have 2 more rounds of Q&A
Okay.
after the index cards are finished.
Okay.
Okay.
So
How do I do that then?
We got to finish the index card and we rate it.
Oh, okay. Can you explain how to take a drug holiday?
It kind of, usually they'll do it kind of like over a weekend or something like that. So if people are noticing that they're having a lot of sexual side effects or things like that, then maybe they'll take their antidepressant throughout the week, and then on the weekend when they have more time to spend with their partner, then they'll kind of just not take it for those couple days and then go back on it.
Can withdrawal from Zoloft cause involuntary eye blinking for months? Would this be considered TD? If so, would resuming Zoloft help?
We saw this card when we first came in here, and we're suddenly like trying to look it up because that's something that we don't really think of, that isn't very common. And in the 5 minutes that we were looking it up really quickly, it doesn't look like it would be likely to be TD just because of the way the drug works. However, there's sort of 2 ways to think about it. One way is that sometimes some antidepressants can be used to treat tics. And I don't know how long the person who would have been on Zoloft had been on it, or if they would have known they had a tic disorder ahead of time. So if someone had say you'd been on it for a very, very long time, and you were to go off of the Zoloft, and you had either some sort of tic disorder that was becoming unmasked by taking off the Zoloft, that's one thing that could happen. Also, we did find a couple of case reports of Zoloft actually causing some tic disorders, but that would be less likely to see that upon stopping the Zoloft. Mm-hmm. But it sounds a little bit more like a tic than actually tardive dyskinesia. But if you're thinking restarting it may help, if it is indeed a tic that got unmasked, restarting the Zoloft may help with that. It just kind of depends on why the Zoloft was stopped in the first place. Because if it was stopped for a reason, you don't want to just, restart it and go back to whatever reason that it was stopped for. But that was the information that we could find in that amount of time.
And remember, tardive dyskinesia can occur without any drugs at all. Mm-hmm. It was described way before medications even were used. So that movement can happen without any medications at all. So what do you say to a patient whose goal is to stop taking medications, right? Whose goal of taking medications is to get off medications? Did I ask that right?
I guess that would really depend on the reason why the person wants to get off of the medications and kind of where they're at, like we talked about before. How stable is the person? What is the risk if you go off the medication? Why are you going off the medication? Is it just because there's a side effect? Maybe then we could switch to something else or try to manage it. Or if it's something where the person is just opposed to taking medications in general, then it's something you could kind of maybe try to work out and see on an individual basis whether the risk is worth the benefit.
How do you tell if sedation is from depression or medication?
It's a good question.
I think, I think one of the ways that I try to ask whenever I'm talking to people, like in clinic, who've been on a medication, is really trying to figure out the timeline of what's going on. So whether someone was depressed but wasn't feeling sedated, we start a medication, they're suddenly sedated, then it would make sense that it's more likely caused by the medication. However, if they were sedated to begin with and that's just continued, then it's likely due to, the depression itself. But you kind of have to also take into account that if you're remaining sedated, it could either be due to the fact that the medication is also sedating, or we're just not effectively treating the depression. Mm-hmm. But I usually look at the timeline to kind of determine whether, this is caused by the depression or the medication.
Or you could switch when you take it.
Yeah, well, that too. Yeah, if you're feeling more sedated, try taking it at bedtime.
How does metformin cause weight loss? Ooh. Glad I'm not answering that one.
Oh, geez. How does it cause weight loss? So I know how it can help with high blood sugar. So what's it do? It helps with, what it does is whenever gluconeogenesis. Okay, I'm pretty sure what it does is, so your liver is involved in turning sugar into what they call glucagon. What? Why are you laughing at me?
Because we noticed that people lost weight when they took metformin. I don't know.
Okay.
Well, that's kind of the truth, actually. They just
So it's probably they use it in diabetes, and it pretty much takes the sugar out of your blood and puts it like into your muscles and allows it to, build up. And I think that patients who had diabetes, who had this medication, were experiencing weight loss. And I think that it partially could be due to the fact that it's taking the sugar out of the blood, but also the fact that metformin sometimes can suppress the appetite. And some people notice, this is quite unfortunate, but some people notice like a little bit of stomach upset, or they may be less likely to want to eat. So that also could be contributing. But I don't think that's the only reason, because if it was just making you feel sick, then nobody would want to take it. But I think that they think that the appetite suppressing effects are also part of it. So sorry to get all technical and make people laugh.
Oh, okay. Somebody's going to have to help me with this one. What do you suggest for the side effect of numbness? What do you mean by numbness? Numbness in your head, your arms, your fingers?
Like emotional numbness?
Your brain? Numbness?
No, just feeling like
Blank?
blank.
Ooh.
Anhedonia? Yeah,
Anhedonia? Ooh.
Yeah, some people do complain with certain, even lithium or antidepressants or antipsychotics, that sometimes they'll feel kind of like zombified, or just sort of like, I feel like I don't really have emotions anymore and I'm just kind of shuffling through life. So I think with that, it kind of depends. Sometimes you can try lowering the dose and it can help, or you can try switching to a different medication and see if that's a little bit better.
Yeah.
I don't know if you have
Probably lowering the dose initially.
Yeah, and then if that's still problematic, trying to switch to another medication, because you don't want to have the problems, but you also don't want to lose your feelings completely.
Okay, Tuffy. Please address marijuana use with medications.
Do you want to go? Or do you
Okay,
want to go?
so are there drug interactions? We'll do it this way. Are there drug interactions with cannabis, marijuana use, and medications? This is like a whole half an hour talk right here. We'll come back and do this one.
I haven't actually heard of specific drug interactions like through changing the levels of drugs or anything like that specifically, but I would think that if you're on a medication that could cause like sedation or things like that, then there could be additive effects. I don't know if there's anything else that you've heard of.
Yeah, there's also certain effects with because of marijuana and how it affects dopamine in the brain. Sometimes people who experience psychosis, like with schizophrenia or bipolar, they notice that sometimes smoking marijuana can make psychosis worse, especially nowadays, since it seems like marijuana has been getting stronger over time.
Yeah.
I don't know if this is true of marijuana, but I know with smoking cigarettes, something about having not the nicotine, but actually having like the burning carbon and inhaling that can affect the way that your liver processes drugs. So I'm not sure if that might also happen with marijuana or not.
I don't
think so. I think it's specifically with cigarettes because they activate certain enzymes in the liver that make the liver metabolize certain drugs a lot more quickly. I don't know that that's true with cannabis, but so I don't know. I don't think we've studied cannabis enough to really know all of the drug interactions, but luckily we have been, because of a lot of the states legalizing it, that we are studying it a lot more. In fact, the FDA last year was the largest consumer of medical marijuana this past year, and that was for research. So
A lot of our research is white.
yeah. Well, I'm really glad, because it's about time that we're actually, investigating what people are actually doing and using, so we can find out drug interactions, and are there health risks? Because people are doing it. We shouldn't just turn a blind eye to this. We know that this is a medication that stays in your brain for a very long time. So people can feel the effects of it for 5, 6, 7 hours. We know that it's sedating, so it's going to be additive to any medication that's sedating. And we do know that it is classified as a hallucinogen. So if people suffer from hallucinations, this is a really bad idea because it can make that much, much, much worse. So people who have paranoia or hallucinations, this is something that we would really highly recommend that they stay away from. There's some evidence in the literature, both positive and negative, that about it with PTSD, it with anxiety. So you can look at the literature and you can find studies that say, oh, it's helpful for anxiety, and then you can look at the same literature and find, oh, it's terrible for anxiety. So you can find something either way to support what you want it to say. So yeah, which one you want to read and believe, you can find either one, and it's kind of up to you how you want to feel about it. Unfortunately, the laws still are, the federal government is still the federal government, and if you test positive, it'll stay in your system for a month. So we still use the blood tests that show, even if you smoked it a month ago, it's still going to show up in your system, even though you're no longer intoxicated from it. We don't have something that shows you are intoxicated. No, you're no longer intoxicated. So we don't have that test yet. So that's the other negative, is that it's still going to show up.
With the method of smoking, from the whole scale of a roach versus a vaporizer or a cookie, would the method of ingestion affect? Does it hurt the lungs enough that this is going to cause anxiety?
Well, I don't like anything that you have to smoke. Smoking is damaging to your lungs. It's hot, so it's gonna damage that epithelial layer of your lungs. I don't know if you guys remember in your biology class, if you were to take your lungs, that whole lining of your lungs, and you were to lay it and iron it all out, it would be as big as a football field. And you crinkle it all up, and that's your lung lining. That's how much lung space we have. And so when we breathe something in and it's not oxygen, our lungs the oxygen, or our blood will bind to it stronger than it binds to oxygen. So it binds to carbon monoxide preferentially. It likes to bind to that more than it likes to bind to oxygen. So we really need to be breathing oxygen and not all that other crap, especially cigarettes. And we can damage that, because that's like so fine, fitting all into there. You think about it, a football field crinkled all up and fit into here, that's really, really, really fine, and we can damage it pretty easily breathing in something that hot. So first of all, don't smoke. Don't smoke it. Smoking the transit time that goes from your lungs to your brain is super fast. This is why smoking a drug is so much more addicting than any other way of taking a drug, because it goes boom straight into your brain. So it's almost, well, it's actually faster than injecting it in your vein and going to your brain, is smoking it. And this is why a lot of times people who smoke crack or smoke anything get addicted to it so much faster. So that's my first pet peeve, is don't smoke anything. Don't smoke any drug. If you're gonna do it some other way, or at least cool the heat off. So the vaporizer is at least better because you're not smoking, burning leaves. You're breathing in a vapor, and it's not necessarily a hot vapor. So.
And I remember years and years ago, a man whose place was with pygmies who smoke marijuana. They think it's a gift of God to them. But his comment about us here, this culture, was these people smoke too much. It doesn't take that much to get high.
Yeah. Well, people here do it to get high and to alter states, and medicinally, it might be a different story. We might be doing 1,000 times more. We just, like I said, we don't know enough about it. There's cannabidiols versus tetrahydrocannabinol. There's all kinds of information out there now that we just don't know enough about yet. Okay. Is that good on that one? Okay, good. All right. How does Vyvanse fit in? What does Vyvanse?
Vyvanse fit in? So that's the lisdexamphetamine, right?
Yeah, so that's a stimulant.
Yeah,
that's
it's a
usually
stimulant.
something that they use to treat things like ADHD. So generally for bipolar disorder, we don't necessarily recommend stimulants, unless there actually is like an ADHD component or the bipolar is being well controlled, because stimulants can actually precipitate mania. Sometimes for folks who have more issues with depression, if they have really like refractory depression that's not responding to other medications, sometimes adding a stimulant can help. But Vyvanse isn't necessarily something that we'd, go to for folks with depression or bipolar disorder.
I think the one thing about Vyvanse that makes it a little bit different from some of the other stimulants is that it's made in a way that makes it very difficult to abuse. So I think that's why a lot of people will choose to prescribe that. I know it's hard at the VA because we have a formulary, but just the way the medication is made, you can't actually, snort it or inject it. It won't work that way. So that's why you may see Vyvanse more than some of the other agents. But like she said, it's not something we typically use for bipolar disorder.
How about depression?
Like she said, it can.
Oh, sorry.
Yeah, you can use stimulants in people with depression, especially if they have very low energy or have a lot of that anhedonia type feeling. It can help to give a boost, but always have to have caution, especially in patients with bipolar.
Okay, last question from the bag. I'm gonna just edit this one and just ask. Can you maybe bipolar 1 thrive on a half of a therapeutic dose of lithium if they're doing all of the other good behaviors, attending the self-help, no alcohol, no caffeine, exercising, etc.?
So I think if I'm correct, the question kind of was, say there's someone with bipolar on the spectrum, they're kind of midway, and they're on a therapeutic dose of lithium, and they're kind of asking, they have a friend who's, far over on the bipolar 1 spectrum side who's managed on 500 milligrams, and kind of the question again was where.
Well, can they
be managed on?
Can they be successful on a therapeutic dose?
I think
on a half of a therapeutic dose.
Yeah, I think like we were saying before, it's very patient specific. So 1,000 milligrams or 900 milligrams may be therapeutic for one person, whereas it may be too much for another person or too little for another person, because our bodies are different in how we process lithium and how quickly it gets out of the body. And also some people, even if they have the same level, they're more sensitive to the lithium. So they may experience, the lithium may actually work more strongly in different people. So going based off the dose can be sort of a, kind of a not very patient specific. So meaning that, someone who has a severe bipolar 1 disorder may be able to be managed on a lower dose than someone with, bipolar 2. It just really depends on how that person's body handles the lithium. And it's it's very patient specific, and finding out with your provider if you can manage on a lower dose, and trying to find that perfect dose for you. And I think it's different for everyone, despite what spectrum of bipolar disorder they have.
Yeah, the motto we usually go by is treat the person and not the level. So, I mean, if somebody's been on half of a therapeutic dose for 20 years and they've been stable, it's not like we're going to, double their dose just because. So, if they're doing well, just leave it alone.
But don't feel bad if, you think, oh, this person's severely bipolar 1 and I'm not, I'm on the spectrum halfway. Why am I on more medication? It's just because bodies are different.
Okay, the next round of Q&A, we still have the audio recording on, but you can raise your hands and ask any questions. And after all the hands are gone down, we'll turn the audio recording off, and then you can ask more questions. So, any questions? Andre?
You mentioned caffeine really quickly in combination, so I'm assuming caffeine has the same properties of dehydration like alcohol, and is that the main reason why caffeine is contraindicated with a lot of the medicines?
Well, I think that I'm not quite sure about it being contraindicated. I know that caffeine, first of all, can, be stimulating. So with things like anxiety, it can sort of make that worse. If someone were to drink a lot of caffeine and were to get dehydrated, then theoretically it could cause the lithium level to increase. But there's also some thoughts that caffeine may actually decrease lithium levels. So I don't know how you balance that out.
Well, caffeine can also make you manic.
So it's kind of at your own
or hypomanic.
risk.
I don't know. Wait, I've had a couple patients who've gotten hypomanic on caffeine or have abused caffeine. So
what about, just to follow up, what about like kind of the balance for the cycle, right? So if you're depressed, people who self-medicate, if we took and when I say self-medicate, I don't mean adjust their prescription meds. I mean, there's a typical bipolar cycle with alcohol and cocaine, for those that can afford it, where you're manic, you drink a lot, you get depressed, you do cocaine, you feel better, then you require increasing amounts of both drugs, and then you're in real trouble. So if you were to have a cup of coffee because you're sedated from your medication and you're in a depressed state, could that bring you back to euthymia as opposed to make you manic? Like, is it that much of a switch that it's just, even if you're on, multiple other meds?
Yeah, we see that quite a bit, where people will, they'll tend to do this teeter-totter, and it will be with something as simple as, caffeine, a couple of cups of caffeine, and I've seen people escalate until they're drinking, 2-liter bottles of Mountain Dew, and to escalate their mood, and it's just a slippery slope, I think. It's trying to counter the effects, or a lot of people don't want to. They don't want to feel depressed, or they don't. Maybe the euthymia, the normal, is boring, or not as much fun as the hypomania or whatever. They want to feel that up a little bit more, and caffeine might be the way to do it. So I think that's a reason to avoid it, and to try to do things a little bit more, naturally with exercise, and just trying to avoid things, especially because caffeine does have drug interactions, and some
addictive.
Yeah, and it's just got some bad health things. And I think you had your hand up next. Sorry.
Before Viagra is prescribed, is microvascular disease ruled out?
I think it should be.
Is it?
Well, it depends. It depends on where you go. If there's a direct cause, we give a medication and there's an immediate, then a lot of times no. But if there's underlying risk factors like diabetes, then yeah, we will often send people to urology or to another specialty clinic to also have other other specialists evaluate them, and that's a good practice, is to go to the primary care or to a specialty clinic just to get another person to evaluate you, just to have overall health care needs taken care of.
I think there's a question in the back.
Oh, sorry.
That's just, generally speaking, what overall, does the thyroid effect have on this, or does the thyroid have anything to do with this stuff?
It can go both ways. I mean, you can sometimes have folks who take lithium and it affects the thyroid, but also if there are problems with the thyroid, then that can definitely affect your mood. I mean, if somebody's thyroid is not working optimally, then they can definitely feel tired and depressed and kind of appear like they're depressed, but it might just be a thyroid problem.
So that's something that before treating any mood disorder, we always hope that the provider will measure thyroid levels, because it could be something as simple as correcting the thyroid in people who are presenting for the first time. But also, lithium can have effects on the thyroid, and like we said before, I think usually they'll try to treat the thyroid rather than switching the lithium, especially if someone's very stable on the medication.
Yeah, SSRI antidepressants taken long-term, say 10 or more years, will they cause insomnia? And if so, and I think they do, will it go away?
I've never actually heard of that happening. I think that with a lot of these medications, everyone responds to them differently. I don't know if either of you have heard of that and happening in multiple people.
Often side effects occur initially and then tend to taper off as you take them and get used to them. I don't usually hear of people developing a cumulative side effect so that you would develop something, 10 years down the road. So often people, they get insomnia, it will stay with them, and they'll have it for 10 years with an antidepressant.
No, I've stopped it and it's continued.
Oh, and the insomnia has continued?
Yeah. And I've heard this from people taking these, that they get that.
That they get insomnia and it just doesn't stop. I don't know. I know that sleep is a very habitual thing, that we get really, really used to sleep, and that we do need to change our habit patterns, because we are creatures of habit, and we'll very rapidly our habits will be able to change. Like, we'll get used to taking a nap during the day, and then we won't be able to get out of that habit very quickly, that kind of thing. So so we can change some of our behaviors with sleep hygiene. I think maybe you've heard of sleep hygiene. I don't know that there's anything about the antidepressants themselves that actually affect sleep architecture. Most of sleep has to do with melatonin, and the antidepressants don't really affect that gland or that. So I I've not heard of that. I know that our bodies and our need for sleep changes over time. So as we age, naturally our sleep gets worse, unfortunately. Yes.
I wanted to ask a question about nicotine, not so much through smoking, not so much interaction with medication, but I always assumed that the negative was the risk of cancer, but you were mentioning other things that smoking cigarettes might do to the body. You know that 95% of people with schizophrenia, I've read, smoke cigarettes. A lot of people with depression smoke cigarettes. So there is some anti-anxiety effect that they report. So what causes that? And then in those instances, would you still recommend that they quit smoking, and why? I mean, what would be the pros and cons?
The pros to smoking are that it may have some anti-Alzheimer's protective effects. The cons are that people die from it. I mean, they're cardiovascular disease, and we haven't been able to isolate what exactly it is that is the that's preventing the Alzheimer's or what the benefit is. So we don't really know what it is. We can't even give somebody like a nicotine patch and have that work. So I don't know what it is. Nobody knows what it is. It could be that maybe people who smoke are well, I don't know what it is. Nobody does. And it just seems like the risks have always outweighed any benefits. The drug interaction is the same thing that's in hydrocarbons. How do I explain it? It's the same drug interaction in charcoal foods that.
It's
what other
like
drugs?
it's the smoking itself, not the nicotine.
Yeah, the smoking itself can cause like decreases in certain drugs. Like if someone was on something like clozapine or Zyprexa, but it's the combustible products from the smoke being, or from the cigarette being smoked, and not the nicotine, itself.
Okay. So is that like destroying the esophagus, or what?
So as far as the the combustible products in smoking, that, like she was saying, can destroy the lining of the lungs. It can cause oral cancer. It can cause esophageal cancer. Can cause heart disease. I think it's even been linked to other cancers that are farther away from the lungs. So thinking about it in the whole scheme of risk versus benefits, it does appear that the risk greatly outweighs any potential benefits. And it's kind of unclear why some of the people are smoking more. Like it could be due to some of the like decreased anxiety effects, but also since other people, if a bunch of people with schizophrenia or whatever are around each other and some of them are smoking, it can also be sort of a social thing as well. So there's a lot of different.
But there's also, she's right. There's like 95% of people with schizophrenia smoke. So there's something else going on with the disease itself, the illness itself.
Mm-hmm.
There's some anti-anxiety.
Or
I've heard that.
Or not just anti-anxiety, but something with schizophrenia itself that makes such high rates of smokers in schizophrenics, and we don't really know the answer to that one either. Yeah, when I worked at a state hospital, we had 97% of people in the hospital smoking.
Just to dovetail on this one, yeah. I'm trying to think of this because this has been a discussion we've had in our family. Is it the idea of the effect of the nicotine has nothing really to do with the nicotine itself, but actually has it within the combustibility of the cigarette. So there's somehow an effect in there that affects certain people because, I understand how tobacco became an issue years ago. I mean, it's a social thing. But it was always devised in the idea, it was looking at nicotine. But like you said earlier, you tried even with nicotine patches and it doesn't have the same effect. Okay. I'm trying to get, because they say the two most addictive drugs are nicotine and caffeine. So I don't know if that's true. I've always tried to say how this was, because this has been an issue in our family, is to wonder how it was, because we've lost a lot of family members because of smoking. An enormous amount. That's not good. So that's the one thing I was trying to get some clarity on. So thank you.
Well, kind of like Susan mentioned before also, things are more addictive when they get into your brain more quickly, since kind of what makes people feel good is like how quickly it's getting up in there, not necessarily the amount. And when you smoke things, they get up in there like really fast. Whereas if you have a patch, it's going to be kind of more gradual, so you're not really going to like feel it as much.
Are there any new medications that are being studied or in a pipeline to treat bipolar disorder? I know that Latuda is a new medication. Anything else on the horizon that's showing promise?
Not a lot of things that I know of that act differently from what's already out there, but you're a lot more familiar with the research than I am.
Not enough money.
Yeah, I don't know right now. I'm holding out for stem cell work.
I had a question on, I've read a lot of statistics about mostly monotherapy and drug refractory patients. So like, for example, you might say 40 or 50%, depending on what study you look at, of lithium and bipolar may not be effective. But when you start to use combination therapy, I was wondering how often you find patients are just drug refractory, where they're experiencing more and more of the side effects and not really becoming mood stable or euthymic.
Say the first part again.
In monotherapy, you see a lot of statistics, like if you look at lithium alone or Depakote alone, they'll say that the patient might be drug refractory 40 or 50% of the time. They're only classified as 40 or 50% effective. So when I was just wondering, when you start getting into combination therapy for bipolar with psychotic features, you're generally not on just lithium.
Right.
And in severe cases, you're not on just monotherapy. So when you're on combination therapy, how often are you drug refractory to combination therapy?
I don't know what the literature is on that. Do you?
Not for bipolar. I mean, there's STAR-D for depression.
What does the depression one say?
I think it was like for the depression literature, it was like every like subsequent thing you switch somebody to or add on, like a smaller percentage of people like at each step might start actually responding. But by the time you're getting to like, this is, the fourth thing we've tried, then not a whole lot of people might be responding. And usually if people are on more than one thing, it's usually because they're what we call like partial responders, because if you put someone on something and it doesn't do anything, then usually we'll just take them off, because otherwise all you're doing is causing side effects.
So your sense is it probably gets better with adding more treatments, but I mean, some of the numbers, when you look at like Depakote alone or lithium alone and bipolar, they're like 40 or 50%.
And I think it depends on what phase of illness you're in, if it's bipolar depression or bipolar mania. because we have so many more treatments for bipolar mania than we do for bipolar depression. And yet the majority of patients are in the bipolar depressed phase. And then if you're or if you're talking about a bipolar mixed or a bipolar rapid cycling, then I think that's a lot harder to treat. Getting the regimen cleaned up, getting them out of a mixed episode, getting them out of rapid cycling, and getting them into at least a more comfortable state, and decreasing the cycling, because a lot of times people aren't gonna be able to be symptom free, but their symptoms, their episodes will be much less, and their in between states will be a lot less. So you might still have mood episodes, but they'll be every 4 years, and they'll be, the peaks and valleys will be a lot more manageable. It won't be so detrimental. It won't require, moving across country or losing a job or anything like that. It might just be a leave of absence for a week, or, it won't be such a life-crushing thing like it can be.
Okay, so before the next question, we're going to turn the audio recording off, and the remaining Q&A is pretty much